Okay, so let's get started. Before we can get started, let's understand what a prior authorization is and why it is used in healthcare. We're all familiar with what a prior authorization is, but for our own benefit today, I believe this is a very good definition of what a prior auth is. And as we know, to an insurance company, the use of the prior auth process is a means of cost control, but it also assists an insurance company with ensuring that quality of the service is performed, as well as a means of fraud prevention. We're seeing a lot of fraud prevention these days. Most contracts between an insurance entity and a healthcare provider contains language on the responsibilities of each party in the prior authorization process, which is why it is so important for managers to maintain collaboration and communication with the legal or the managed care team when it's believed that those responsibilities have been violated. So last year, CMS, in its final rule, aimed to enhance the exchange of health information and to streamline the prior auth process for all government programs, including Medicare Advantage. It required the implementation of patient access to data regarding the prior authorization process, which will improve communication between physicians, hospitals, and insurers. Some of these provisions require compliance deadlines by the end of 2026. Also, just a few months ago, under a pledge between CMS and large insurers, these healthcare insurers pledged 6 key reforms aimed at cutting red tape, accelerate care decisions, enhance transparency to their members. They also pledged to standardize the electronic prior authorization submissions by using what is called fast healthcare interoperability resources, or what you might hear often is FHIR. Reduce the volume of medical services subject to prior authorization, and all of this is supposed to be taking place by January 1st of 2026. It also is supposed to honor existing prior authorizations during insurance transitions so that it ensures continuity of care, to enhance transparency and communication around prior auth decisions in appeals, as well as expand real-time responses with real-time approvals by 2027. And finally, and this is the big one, this is huge for us, it ensures that a medical professional is reviewing all clinical denials. So I don't know about you, but my fingers are crossed. These are huge wins to providers and patients. Okay, Eric, next, please. So for the benefit of everyone watching, I'm going to use utilization management and clinical reviewers interchangeably. Utilization management is found in the hospital setting with inpatient stays, while larger group practices will utilize clinical reviewers in the authorization process. And why do we need utilization management? Simply, it's a step in the authorization process, ensuring medical necessity compliance with what service the physician has ordered, the medical inpatient stay, or a service that is in the treatment plan that was developed by the physician and the clinical team. Now, while there should be another team in the business office that investigates if a service or inpatient stay is a covered benefit under the patient's insurance, the utilization management team serves a very important role working with not only the clinical team and the physicians, but also with the business office teams. And to do what? To ensure that, one, The documentation about the service is well written and appropriate for the service that is provided. And two, to know that they are reviewing the medical policy of the correct insurance. I cannot stress enough the importance of running insurance verification frequently. Those few dollars that it costs to run insurance verification can save a hospital or practice so much money in terms of write-offs. Okay, next, Eric. Okay. Carla, can you see Eric? See Eric? There we go. Awesome. Okay, so I created this workflow process as a visual to show how the prior authorization process works. Now, in your organization, this might slightly differ, or there may be some additional steps that your leaders require. But from a very high level perspective, this workflow is pretty standard. So just as a high overview, let's review. I intentionally left out the front office process, so let's just assume that the front office did their job correctly and insurance verification was ran appropriately, and that we are for certain the insurance is correct. So as you know, after the utilization management team has completed their review and have approved the service as meeting medical necessity criteria, it goes to the prior auth team for submission, or it may be in your organization, the utilization team or clinical reviewer is tasked with submitting the prior authorization request. And as we all know, it will either come back as either approved or denied. And as we start to understand why the prior auth was denied, we always need to know the process of the peer-to-peer review. Now, working with several various insurers in my line of working different service lines, and also within different practices and hospitals, each insurer has a different process of when a peer-to-peer is optional. Know that process for the major insurers in your market, and always ask about the peer-to-peer process if you happen to call an insurer about that denial. Also, I can't stress enough the importance of documenting your steps in requesting and receiving prior auths, the outcome of a peer-to-peer, and pertinent information about the prior auth itself. That information becomes important to the back office staff when working a no auth denial from an adjudicated claim. So Eric, next please. So we've completed our research and we know that we've met medical necessity compliance, and any of the forms that are required to be submitted are correctly and completely filled. So now we need to focus our attention on understanding what documents from the medical record should be submitted with our prior auth request. My advice before starting to pull medical records, documents from the medical record, is that you know why the service is being ordered. Now I've come from oncology. Oncology is very complex. So there are many, many different drugs that we give to a cancer patient undergoing chemo. We also administer a lot of drugs that are used for symptom management. If you're working a denial for no auth, it met medical necessity criteria per the clinical review or utilization management, and the date of the administration coincides with the dates, but the drug is being used for symptom management, let's say MVD, nausea, vomiting, diarrhea. You'll want to include the office visit note where the physician highlights that the patient is experiencing MVD and how bad the MVD is to the patient. Now, a good physician's documentation will also include ADLs or maybe ECOG scores. Just to kind of give you a little bit of history about an ECOG score. An ECOG score is used in oncology to score a patient's level of function and how the disease impacts their daily living. The scale ranges from 0 to 5, with 0 being fully active and able to carry on all the pre-disease activities without restrictions, and 5 indicates death. It's this type of information is what the clinical reviewer is looking for. Now, as for outpatient surgical procedures, if possible, try to get a copy of the PCP's office visit note that talks about the advanced findings of the patient's health and the need for the referral for surgical needs. And of course, always include the consult note from the surgeon. Include any diagnostics that are related to the need for the surgical procedure, whether that is being any type of imaging, ultrasound, or an outcome from another non-invasive procedure. Eric, next, please. Oh, yeah. So by far, I know this is a very short list of the reasons why a prior auth gets denied. I know all of you could add to this list based on what you've seen working with different insurers. 2 denial reasons that happen frequently and warrants further research is that an insurer will tell a prior auth team member that a prior auth is not required when actually it is. So before you call to confirm if an auth is required, do your homework. Most insurers will publish their prior auth list online, making it easy to understand if a prior auth is required. If you find yourself calling the insurer to confirm the need for submitting a prior auth request and they tell you one is not needed, well, be sure that you are armed with knowledge in order to push back. Always push back when they tell you no and you know that that's wrong and that an auth is required. And ask them what the request requirements are. Now, what I've also seen is another type of denial is when the auth request has been approved, but the medical necessity criteria was not met, either because the physician documentation did not support the need for the service, or the incorrect missing documents were not submitted with the prior authorization request. I see insurers now approving auth requests without a medical review, probably because of staffing issues on their end. And for those working with prior auths for drugs, be sure to double check the medical policy while there is a big push at the insurance level to use biosimilars. There are many insurers that also accept a brand name drug or one drug over another drug, but it has the same HCPCS code. So be careful with those. And also too, physicians may order a brand name drug, but the policy requires a prior auth for a biosimilar. So be sure that you talk to your physician or your clinical team to correct the signed physician order. Okay, next, Eric. Yeah, some common challenges. So we've all got stories, you know, of all the things that could go wrong when working to get that prior auth. I've always found that with prior auth teams, these seem to be the common challenges. And so now let's bring AI into our conversation. With all of the regulatory changes coming, you'll see AI being used more frequently in determining the outcome of prior auth request. And while it will be difficult to determine if AI was really used in the final decision to not approve a prior auth, we still need to be cognizant to try to identify if AI was really used. We also need to be aware of what we're doing. Are we completing all of those required forms to get that timely submission in? I've always had to stop, and I always tell people before you send it, just stop and do a double check of your work. And we see hiccups in our daily workflow. Sometimes the days, it just doesn't go as smoothly as what we had planned. And as we continue to learn about the prior auth process for traditional Medicare and what future services will require prior auth, we still need to ensure that through our research that it meets medical necessity compliance. And we do that by understanding which LCD or NCD is applicable to the physician ordered service. So next, please, Eric. So some common solutions. When we see portal issues and access to faxing documents becomes more of a hindrance to completing our tasks timely, we need to document these types of issues. And I say this because these types of issues can be addressed with insurers at the time of contract renewals. And as I mentioned earlier, within a contract between the insurer and the provider, there are guidelines on responsibilities between the insurer and provider relating to the prior authorization process. So in researching the auth process, if you know that correct medical records were submitted and you utilize the correct medical policy for the correct insurance, but the prior auth still got denied, then we need to start thinking that maybe AI was used and the algorithm is incorrect. We need to make notation of that. We need to document that. And again, our workflows are loaded with cases to work, but it's always best to take a short break to double check our work before submitting that prior auth request. And by now, with the upgrades to new billing systems or to an existing billing system, there should be methodology in place to catch existing auths for recurring services. So next, Eric. Okay. So now that you've researched the reason behind the denial of the prior auth request, are you ready to draft an appeal letter? This is my format for Part B appeals. I always like to start my letters with an introductory paragraph. You're making a statement that your organization believes that the insurer erred in its judgment to deny the prior auth request, and that all the documents within the request pertaining to the need for the service is warranted under the insurer's medical policy. The second paragraph is all clinical data you found regarding the need for the service and supporting physician documentation that is related to failed therapies, diminished labs, imaging findings. I will copy and paste verbiage from the office visit note, the consult note, imaging findings, anything that's regarding the patient's health as it applies to the physician ordered service. So next is the third paragraph. It is all strictly regulatory. It talks about you documenting any type of research that you have done, payer policy, if traditional Medicare, list out the appropriate LCD or NCD, and any other supporting evidence that you find, maybe from a peer-to-peer journal, NCCN, which is National Comprehensive Cancer Network, or from just a medical journal. And at this point, if you feel that the service that is going to be provided isn't going to quite meet medical necessity compliance, and you visited with the clinical team and the physician, and you were able to get that letter of medical necessity, I would definitely slip in a little paragraph here to alert the medical reviewer that the physician did allude to more facts about the need for the service based upon the health of the patient and the interpretation of any peer review articles the physician used to make the determination that the service is warranted. And then lastly, the last paragraph is bringing the clinical scenario together with the regulatory to justify the need for service. Always thank the medical reviewer for their time. If appropriate, request a peer-to-peer instructions. Request a thorough and complete review of all documents with the appeal letter, and that you are looking forward to an overturn of the denial with the appropriate authorization number. So now I'm going to turn the next portion of the presentation over to Carla, who will talk to you about Part A, prior auth denials in the front business office. Okay, Carla.
Okay, thanks, Deanna. So, yeah, we're going to talk a little bit about Part A, and sometimes wrong information is used to seek authorization, and you need to really evaluate, where did that come from? Did it come from the payer? Did it come from the patient or the family? I mean, these are always areas where there could be error. Sometimes no insurance information is available. And there's a lot of reasons for that. The patient could be confused. The patient could be unconscious and they don't have any information on their person about the insurance. So these are things that are not the fault of the hospital. It's beyond their control. Emergent conditions, no time to ask, and it's just not a reasonable thing to ask about given the situation. So those are all things that need to be pointed out. And we're going to talk a little bit more about that. Okay, Eric, next slide, please. So you need to explain whenever you are appealing something like this. Explain why it was not the hospital's fault for not obtaining authorization. And there can be 1,000 reasons for it, but you want to look at the medical notes. You want to look at the patient accounting notes. And when I was in the hospital working with denials and appeals, I didn't even know what patient accounting notes were. And you can find a lot of information in there that can be very helpful. The patient's condition on presentation and the time the decision to admit was made. Maybe the patient was by themselves and they're just not in a condition that they are able to relay what their insurance is. It happens all the time. Okay, next slide, please. So these are some examples of how you might explain these extenuating circumstances. And we've heard you loud and clear, over the past couple webinars that you want to see actual wording about how to appeal. So this is some actual wording that you can use for different situations. And you need to adapt it, of course, but you need to use the words extenuating circumstances. These extenuating circumstances existed that prevented the hospital from requesting inpatient authorization in a timely manner. Please consider the following. So here are some examples for you. Mr. Doe didn't have an insurance card when sent to the ED, and he couldn't remember what it was. His wife found it, but it wasn't until 4 days after admission. So you explain that extenuating circumstance in as much detail as you possibly can, and then you follow that with an appeal for medical necessity. Because the last thing we want is for them to understand the extenuating circumstances, but say, well, it's too bad, so sad, medical necessity wasn't met. So try to head that off right at the start. Extenuating circumstances, follow it with a medical necessity appeal. Mr. Smith stated she had XYZ insurance. This happens to be an appeal that I did. Hospital staff went into the portal, found insurance information there was an expiration date. The year was 9999. And then it wasn't until after discharge that it was found she had a whole different insurance. That was beyond the hospital's responsibility. There's no way in the world they could have known that. Another one, Best Hospital received inpatient auth, whatever, on this date via a phone call with the insurance employee's name, the date, and use the reference number of the phone call, because they can go back in their records then and look at what exactly transpired. So if an auth number was given, then you need to appeal with that. That's an extenuating circumstance. That is outside the hospital's control if it was an error. John Doe entered the ED via ambulance unconscious due to a head injury. Family didn't know the insurance. Unfortunately, he passed away. Please consider the following notes that verify those facts. Okay, it wasn't, it was out of the hospital's realm. They couldn't have done anything about that. So look at all those things, the PAN notes, the case management notes, the dates and the times. And that's what you want to use. And then an appeal for medical necessity following. Next slide. Okay, Deanna, do you want to take over here?
Okay, sure. So again, most of whether you're doing a Part A or Part B, the documentations from the medical records, you've got to be able to find those specific notes that actually support medical necessity. And again, it's so important to understand what is being ordered and how it plays a part in the patient's treatment plan. And once you understand what that is, how that drug or how that service is going to work for the patient, then go to the notes. You're looking for clinical notes, the physician documentation, anything that's in the impression from the imaging notes that supports the medical necessity that reflects in the payer policy. Again, provider's rationale, if it's not clear, always ask for a letter of medical necessity. Again, there's always extenuating circumstances that also should be outlined within your letter. And avoid unnecessary documentation. I know that a lot of staff leaders will just tell you send everything. Well, don't send everything. Be cognizant of what you send. Make sure that it is it's reflective of what the payer policy requires, such as lab results. Is it requiring a particular lab to be outside of a normal range? Same thing goes for CT scans. If there's anything that is of substance that is in the payer policy, does it match what is written in the impression by the radiology physician or tech or whoever is doing the impression that has been hired by the hospital? Pretty much just be cognizant of what you send. Make sure that you go through the medical record that's in your EMR thoroughly, but also be cognizant to know that the medical records that you are providing is for the service that is being ordered. Okay, Eric. Okay, so Carla, we've got some good time left. So I was kind of concerned about how we were going to be doing on time here, but I think we're going to go ahead and we're going to do a deep dive into this section and move on to adjudicated claim denials for no authorization. So when we're researching our no auth denials, you know, typically we see reasons for no auth denials that the individual in the front office may not get. Totally different ball game whenever you're in the back office. And again, this is a short list. If you're an insurance specialist, I know that you can elaborate on this list as well. I can tell you getting a no authorization denial overturned based on an administrative reason is slim to none. Count your blessings if you're able to get an administrative reason overturned. Most insurers allow a 48-hour window to revise or update a prior auth prior to billing, or to obtain an authorization if the service that was considered emergent or urgent. If that 48-hour window starts late Friday afternoon, and you know that late Friday afternoon, and you know that by Monday morning that 48-hour window is going to be gone, I've been successful with getting those types of no auth denials overturned, but you have to provide dates and times of physician's signed order or what time the service was administered or provided, such as 4 p.m., 5 p.m. on a Friday afternoon, and always state Friday afternoon plus the date. Any other day of the week, the prior auth must be updated or requested within 48 hours. And again, remember, the timing may differ from payer to payer. Specifically for Part B, oncology, and for infusion drugs, I always like to challenge these types of no auth denials when there has been a change in the HCPCS code mid-treatment. Number two, the use of another drug with the same HCPCS code was administered due to a drug shortage. Or maybe number three, if the HCPCS is the only information about the drug on an authorization. My approach to appealing, if that the physician ordered a drug, not a HCPCS code. Now, if the drug is not documented on the auth, a strategy in appealing is base the denial on the fact that you're requesting an auth for a drug, not a code. Always remember, and we always remember that whenever you're working any type of getting an authorization, and you're working a denied authorization on the back office side, always remember you're getting an authorization for a service, not a CPT or a HCPCS code. That helps us on the back end be able to defend why we got that authorization in the first place, and we provided that service. Okay, Eric. So if you're not a seasoned insurance specialist working a Part A or a Part B adjudicated claim denial, it's difficult to stay organized. I've seen a lot of newbies come to an organization and they struggle to stay organized. I still work complex cases, and staying organized is truly a key to being successful in building a strategy of appealing a service. I created this workflow graphic for you for this webinar. So let's just kind of go over it and just at a high level. So it's important to always understand the remark codes that are on the EOB or the remittance advice. And I apologize, I forgot to document on this slide my go-to resource for knowing the long descriptor of a remark code. So I want you all to make note of this website I call x12.org. X, a big X, the number 12.org. And once you go to that website, there's a very large search box. You can either type CARC or RARC. After a couple of additional clicks, you'll get to the list of the universal codes, and it's the long descriptor. It doesn't tell you why, the why of that descriptor, but a lot of times on our EOBs, our remark codes are cut off. So just know that this is a good place to go to get that long descriptor. So next, you'll want to ensure that an authorization is in place. If one is not there, you need to find out what happened. If you do have an authorization, then you need to check the dates on the auth, the CP, HCPC codes, the name of the service ordered, plus the facility and the ordering physician. Also check to see what documents from the medical record were submitted with the auth request. A lot of times I've seen where there has been documents that were not included and it was denied for no auth, when really there really was an authorization there. This will help to understand if you will be challenging denial based on an administrative issue or if it's clinical in nature. So next, you want to do your regulatory research. Ensure you're using the correct payer medical policy. Any peer-reviewed journals or outcome of a peer-to-peer. Next, review the documents in the medical record. If you can't match up the verbiage from the physician or other clinical data to the medical policy, then it might be best to get with the clinical team or the physician to get a better understanding as to why that service was needed. And if your front office did not get a letter of medical necessity, now would be a good time to get that. And when you're determined, and when you've determined how you're going to strategize on how to appeal, then it's time to start drafting your letter. Okay, next please, Eric. So dependent on what service was ordered and provided, this is a good generalized list of documents from the medical record you will want to submit with your appeal. Again, know the service that was provided and find the appropriate documents that justify the need for service. Just don't send everything. And always take a moment to double check your work. Okay, Eric? Now, the My Denial letter that I teach and that I use on the back end for insurance specialists, it's slightly different than the one that I teach to authorization teams, clinical reviewers, utilization management teams on how to draft an appeal. But very similar to, like I said, to the front office denied auth request. This letter would contain additional information as needed. Again, this is a perfect letter for your Part B services. And of course, you're welcome to add any additional references, and definitely always include verbiage from the physician found in the office visit notes and also the consult note. The point of paragraphing your information is to stay organized, which will help the medical reviewer understand the clinical scenario and the regulatory and how they match. Okay, so now Carla's going to take it away and she's going to talk to you about the Part A appeal letter.
Okay, so our purpose today is to talk more about the extenuating circumstances, which I think we did talk about that. But we do have to include the facts that prove the authorization was actually obtained. So you need to use that information, and then you're gonna appeal for medical necessity for inpatient status, just as you normally would. So like I said, our purpose today is not to teach how to appeal for the medical necessity, but to make sure that you have a clear understanding that there needs to be an appeal for medical necessity, but you need to put those extenuating circumstances front and center. And there again, as Deanna had said before, you want to avoid unnecessary documentation. So I always think it's really important in our appeals that we put the pertinent information. If something is normal, that's not going to help support why that patient needed inpatient status. Mm-hmm. So unless you have a reason for putting normals in there, it's not going to help usually a whole lot. One place that I absolutely positively put in normals is when I want to show a comparison. So for instance, if there's a patient who's GI bleeding, if it's very rapid bleeding, and they get to the hospital quickly, their H&H might actually be in the normal range when they come in. But if it's bleeding rapidly, there can be just a precipitous drop in a very short period of time. And in a case like that, I'm going to show what the normal was, and short time later, what it fell to. So that's an example of where you might want to put in normals. But I've seen many appeals when half the appeal is full of normal results. There should be a reason every time if you put in normal results. So that's the main thing that I wanted to get across as far as the medical necessity appeal itself. So next slide, Eric. And these are the references that were used for this presentation. And so we hope that you look up some of this information in the regulations. It's important. It's important that we all understand where these things came from, and the why. We need to understand why. So with that, I think we're ready to open up for questions, Eric.
Great, very good. Thank you both. We do have a number of questions, and since we've got some time here, let's go through a couple of those. The first question: is there any way to get a pre-auth for possible biopsy when getting an auth for a colonoscopy? So doing appeals where they get the auth for a plain colonoscopy, but once viewed the area, they needed to do a biopsy. So, but the insurance then denies the claim for lack of pre-auth for the biopsy. So is there a way to get pre-auth for the possible biopsy? We've got a stumper, maybe. We might have to dig into that one.
It's really, oh wow. If the physician knew about that before going in, and he probably more than likely he didn't know. So if he did a colonoscopy and then and did the biopsy at the time of the colonoscopy, you should be able to go back and update that existing authorization with the additional CPT codes for the biopsy. When a physician doesn't know what's going to happen and he does something additional during a procedure, he should be telling you shortly after that happened that the CPT codes or the service, the biopsy itself that he did, so that coding can go back and understand what that CPT code, and then give it to the authorization team to update an existing one. But it's really hard to know that if a biopsy is needed during a colonoscopy. Carla? I think that's very rare.
Why don't we, I know there's going to be questions that we can't fully answer like right now. Why don't we talk about that? And we will include a complete answer whenever we have our questions and answers that we'll have posted in a week or two. So why don't we, yeah, that's a tough one.
Mm-hmm.
So,
Yeah.
We'll go on to another one here. Is there any way to get an auth on an inpatient-only procedure that was performed on Medicare Advantage case where the physician ordered the patient's admission status as observation? Can you legally appeal this without the inpatient order?
that is also going to take some research. Okay, I think I know the answer to that, but I want to be sure. So we will look that up and we will include that when we post the questions and answers. Okay.
Another one here. How do you feel like a lot of these are pretty detailed or research heavy? But this one, how do you address a procedure that is pre-authorized, but implants and or specialty grafts that are utilized in the procedure are denied because they were not authorized? So procedure was authorized, but the implants or the grafts were not.
Okay, I'll address that one. What we do at Payer Watch is we check to see. First, we check to see was the reviewer correct? Because there are times that the reviewers are not correct. Yeah, it is going to be a tough one. Then you need to look at the payer policy, and has there been a change in the payer policy that the payer wasn't aware of? I've seen that happen. They're tough though. Your best chance, I think, is to look for those things, and also look to see if the physician who did the procedure and decided what to use, if there's rationale for that. Hopefully there's written rationale from the physician. If not, I think the next step that I have taken personally is I look at recent research. Is there research out there that is very current, and the physician who is a specialist in that field, and they keep very on top of things. So I look to see, is there new research, new articles that the physician was more than likely aware of, and based a decision on that the insurance company didn't have their policy updated yet. I've been successful that way as well. But lacking those things, it's tough. It's hard.
Mm-hmm.
Yeah, good question. Good question.
Yeah, another good one.
To add to that, Deanna?
No, that was another good one.
Yeah.
We would have to see the documentation first to understand what the physician did and how he documented it.
Yeah, and something else that we've done in the past is we've asked the physician, okay, where did you get your information? Can you give me a site? Can you give me an article? Can you give me something? And when you explain what it's for, if you explain what it's for, you'll many of them are very cooperative that way, and they're more than happy to help.
Well, we're at the top of the hour here. We could do maybe one more very quick question, and then we'll get the rest of them out post-webinar. So here's one more final question. Do you have any pointers for appealing experimental denials?
Oh, yeah, I've done that before. I kind of look at it as an experimental denial, as I look at it as a non-covered service. And then I'll go to the clinical team or to the physician just to understand the why. Then just start searching around any references that the physician might recommend, and start looking. Always go to the payer policy to understand why it's considered experimental. There may be some information within there as to the reason why. And some of those reasons, hopefully at least one of those reasons would be something similar to what your patient is experiencing. Such as, I would also say there's also types of devices or some type of a service, a procedure that could be sometimes classified as experimental. You may want to go to that device website if it's a device that's providing the procedure, and search their website to understand why it's considered experimental, or to mirror up your patient's medical condition as why it's being serviced. Those are very, very tough to get overturned. But just as long as you're thorough and there's good documentation from the physician as to why he chose to use an experimental procedure or experimental drug, whatever is defining experimental.
And just to add to that, Deanna, which I agree totally with everything you said. They are tough, but there have been cases that I have seen, and I'll go back to that last example we talked about, where there is recent information, and recent research, recent articles, and they just don't, the payer just does not have their policy updated yet. So it's really, really important to scrutinize the policy, and then look, and don't just stop there and say, oh yeah, it's not included in here. They say it's still experimental. Never believe never ever believe anything that the payer says, because it may not be true today. So look it up yourself, research it. Is it really true?
They're very doable and they're very complex, but it's with a lot of patient and a lot of research, and putting all of the information together precisely, you can get it overturned.
If the information is there, yeah.
Yes.
Yeah. But they're hard. Hard questions today.
I know. This is fabulous.
Great. Well, like we said, we will kind of dig into each of those questions and the ones we did not get to, and we'll send those out post webinar here. And just want to thank everybody again for joining us, and thanks again to Deanna and Carla for your time today and your training.
Thank you, and thank you, Eric. Thank you, everyone.
Thank you all. Deanna, thanks for being here with us. Appreciate it.
You're welcome. Thank you, Carla.
All right. Have a great day, everybody. Enjoy the rest of your day.
Bye-bye.